program on Maui. In 2019, we were given a 1-year funding contract from the Department of Health through their Alcohol and Drug Abuse Division program. Our key partners for our LEAD program are the Maui Police Department, Mental Health Kakua, Kahale Akeola Shelter, and Aloha House. And real briefly, so Mental Health Kakua, we bring to the partnership our outreach worker, stability beds, psychiatric services, which oftentimes lead to case management services, and eventually community-based housing. And Kahale Akeola is the shelter, the homeless shelter, and so they bring also stability beds and also long-term housing. And Aloha House is our substance use treatment program. So they have both inpatient and outpatient substance use treatment services. And the goal of the programs include identifying those low-level nonviolent offenders whose criminal activity is due mostly because of behavioral health issues, and then referring those people, rather than them being arrested, referring them to case management and other community-based services. So the LEAD program, when it began, it started with a coordinated street outreach team that included ride-alongs. And so that was our outreach worker and 2 police officers. The ride-alongs occurred 2 times a week, and our model was to listen, respond, locate, and determine. And so we listen to the police radio calls of what calls are coming in. We respond to the calls that sound as if the individual may meet our program parameters. We locate the individual, and at that point, we start building rapport. And then we determine if the individual is an eligible program candidate. So the goals at this point during the street coordinated outreach is to build trust and rapport with the individuals and to create alternatives to arrest. Now, not every encounter ends with an arrest or an agreement to participate in the LEAD program. During these encounters, the outreach worker often does basic assessments and begins to determine what the individual may need. So referrals can begin immediately at that point. So our best practices that we use in the Maui LEAD program include a harm reduction approach, where the low-level offenders are diverted from arrest and given a case manager and referred to other harm reduction-based programs. We use motivational interviewing to encourage individuals to become active participants in their own change process. We use empathy and meet individuals where they're at. We allow self-determination. We understand that the clients or these individuals have their own goals, and we respect that. We develop discrepancy with the client. So we help them see what their goals are versus their behaviors. And we offer support, really unconditional support to these individuals, encourage them for change. We also use the stages of change to assess an individual's readiness to a new, healthier behavior. And we identify which stage they're in and use the appropriate techniques. Our Maui LEAD program services are a very long list, and I will talk about a few in detail and otherwise just list them off. So the Maui Police Department intervention, the homeless outreach worker. We use stabilization beds. So as I mentioned before, MHK and Kahako, the shelter, both have stabilization beds. And when the outreach worker is going out and meeting with the individual, this is generally what they identify as their primary need. So in many cases, if there's a bed opening, we can gather their belongings and take them right to the housing program. That, in addition to getting them away from the possible arrest, that gets them away from an environment and into a new environment where change is more possible. Let's see, psychiatric assessments. So our outreach worker has a close relationship with several licensed mental health professionals, and the individuals can get an assessment, which often leads to psychiatric medications, and to the community-based case management services. So like psychiatric meds, med management, substance use treatment, registration with health plans, applying for ongoing case management, applications for entitlements, getting medical services referrals, and receiving homeless assessments such as the VS-FDAT, enrolling them in HMIS, and enrolling them in the coordinated entry system, with our final goal of having housing placement. So just to give you a few ideas of some of our successes, we have Pat, who had 250 involvements with the Maui Police Department, 47 Maui Police Department arrests, and once they were linked with, he was linked with the LEAD program, he had 0 involvements or arrests. He also was able to get a part-time position, and he currently has housing. Then we have Susan, and Susan had 29 Maui Police Department arrests. She had a 20-year or more history of substance use. And when she was linked with the LEAD program, she had 0 involvements and 0 arrests. She's been able to maintain her sobriety. She has a part-time position. She was reunited with her children. And through the help and a lot of help it took, the LEAD program was able to move her back to the mainland with her family and her dog. And then we have Kathleen. And Kathleen has 61 Maui Police Department arrests with a 20-year history of being homeless. Since being linked with the program, she also has had 0 involvements or arrests. She is continuing to work on her sobriety. She attends an intensive outpatient program. She was reunited with her adult children, and she currently is in housing. So, next slide. So some of our outcomes for our first year were that the LEAD program had made more than 800 direct contacts with people, with individuals on the streets. And 19 of those people were placed in stability beds for up to 4 months each. 18 people received safe housing. 17 people received long-term community-based case management services. 17 people received psychiatric services. 15 people received medication management. And while out on the street with those 800 contacts, more than 600 referrals were made to other community-based services. So I'm going to pass this back to Greg for some closing thoughts.
So just to give you, just before we leave this slide, just to see, you can see 800 contacts. There might be 19 individuals. You can see how many, it may take several days to weeks, to sometimes to months before we actually can engage somebody, so that there's multiple contacts with the same person just to get them engaged, especially if the person is on the street and psychotic. You can see how a police officer would simply not have the time to be able to do that, but by working with the police department, we can begin the engagement process, and they can hand them off to us. So in closing of this, and then we'll take some questions. Some common myths about homelessness is that they're all from the mainland and they all want to live that way. And our experience is about 10% of the overall homeless population are from the mainland. And almost all of the homeless adults with serious mental illness are from Hawaii. And the reason for that is that families get caregiver fatigue. They just don't know what to do anymore. And the person ends up not being able to live with the family, and they end up homeless without any resources. Believe me, and we say this tongue in cheek, but it's true. We've never met a person who ever said, you know, when I grow up, I want to be mentally ill, a drug user, and homeless. No one's ever told us that before. As a matter of fact, it's just a product of just a poor situation, and unfortunately getting involved with the legal system and not having many resources. And LEAD offers that hope. It offers harm reduction, direction, and a way to end homelessness in Hawaii. So we'll be happy to take any questions you might have for any of these areas.
Real quick, Greg, before we transition into questions, I'll give my slide deck and then we'll open it up again for questions.
Okay, thank you.
You folks are ready. Thank you again, Greg and Doreen, for giving us that snapshot view of LEAD in Maui. Right now, I'm going to open it up and share with you folks a little bit about what we've been doing here in Honolulu on Oahu. Everything, you can see it. Okay. Excuse me while I navigate this real quick. Okay. So, Greg and Doreen did a really great job summarizing this and giving you that picture of LEAD. I'm not going to dive too deep into this, but one of the things that I really want to highlight is that there is this sort of barrier or this collaboration, and Kaipo kind of hit it. For those of you that got to go to Kaipo's presentation earlier today, right before this session, talked about that kind of line between public health and public safety and strengthening those ties. And that's really what LEAD is all about. A lot of the clients that end up in, whether it's on Maui, on the Big Island, on Kauai, or here, a lot of these clients that are cycling through the criminal justice system are chronically underserved. They don't get a lot of the resources that maybe more specialized populations get with maybe HIV diagnosis or with maybe a more serious mental illness. And so they kind of slip through the cracks. And so by giving them something very simple, which is just intensive case management, we're able to give them stability and see a lot of really positive outcomes for them and for the community as a whole. A little bit about how LEAD started here in Honolulu. It was a collaboration for the last 3 years between community organizations, HPD, the governor's coordinator on homelessness, and then a lot of social service agencies. Well over 30 agencies meeting for the last 3 years trying to get this off the ground. We've been able to sustain our program or our pilot here with support from the Hawaii State Department of Health, Alcohol and Drug Abuse Division, some grants from the Open Society Foundation, as well as the Hawaii Lodging and Tourism Association. So thank you very much to those folks for supporting this pilot program. A little bit about our theory of change. I can boil all this slide down into a very simple formula. When you increase the stability and the quality of lives for the clients that are underserved in the community, you improve the community. So just by linking people and sticking with them for a long time, catching these folks that oftentimes fall through the cracks, improving their housing stability, getting them back in touch with their family, decreasing their stress, maybe even reducing their substance use disorder or the impact of it. You see a reduction in emergency room use, a reduction of inpatient hospital stays, reduction in recidivism and arrests and incarceration, and sometimes even improvements in business districts. It's certainly been the case in other jurisdictions across the U.S. That have run this. Greg and Doreen had mentioned, this pilot or this LEAD program, this model is throughout the United States now, not just here in Hawaii. And Seattle's been doing it since about 2008. So a very long time. They've seen a lot of these impacts, and that's definitely something that we hope to see here in the future. A little bit about specifically our jurisdiction. It is a small proof of concept pilot, kind of restricted to the area HPD District 1, Sector 1. We go a little bit outside that area. Not all of the clients that we serve are just on the city and county land. Some of them are on state in coordination with public safety and the governor's coordinator on homelessness, trying to get people into these services that are constantly running into barriers of the criminal justice system. But that's about the footprint of this pilot. It's a very small, very specific area to really prove that this intervention does what it says it does and gets people the care that they need. These are for low-level offenses for the pilot phase. Again, this is a criminal justice intervention, not a homelessness intervention. It just so happens that when you look by the numbers, and please, for those of you that are interested, I'll put it up in the questions later as we wrap wrap up, feel free to jump on our website at hhhrc.org. Under the LEAD page, you can look at our year 2 evaluation. But about 97% of the clients that were enrolled in the LEAD program, in the LEAD pilot here in Honolulu, about 97% of them had either a history within 3 years of referral of homelessness, of chronic homelessness, or were currently homeless. So even though we are not a homeless intervention, that is something, if a client needs to work on it, we are more than happy to walk them through. But it is a criminal justice intervention. And those elements of success for this pilot, or at least what has been for us, is providing that intensive case management with low barriers and coordination with the criminal justice system. So working with them instead of only against them. A really great couple of examples. We've coordinated a lot with Help Honolulu, and that is run not by the Community Policing Division, but by the Community Outreach Unit. You might be familiar with their work also with POST, with the Provisional Outreach, I'm going to butcher that acronym, POST, or the HONU Project, which is kind of a shelter navigation center, kind of in the center of our island here. Kaipo did mention that a little bit in his session as well. So when I say low-level offenses, what I'm talking about are a lot of times we're referred to as nuisance charges. I've kind of broken them down. We looked at this is from the first year evaluation. We broke down all of the different citations that people had received 3 years prior to their enrollment in the program. And that 3 years prior was to give us a comparison with where they are now and where they had improved. For the first year, we had seen about a 55% reduction in citations that were issued for our clients across the board. But what I really want to talk about now is the characterization of those offenses. A lot of, Greg mentioned a lot of the stigma that a lot of our clients have against them, that they're out there running the streets, doing all the wrong things, that they're using drugs, and doing a lot of things that are harmful to the community. But when you really break down and look at the history of the clients that we served over the past, the first year and continued on into the second year of our program, the characterization of those offenses kind of tells a different story. The majority of the citations that were issued to our clients, when we look at the history, were either as a direct result of poverty or homelessness, or somewhat related to homelessness. I'm going to go into the categorization of the result of homelessness, but those are like sit and lie, being in a park after hours. For the ones related to homelessness, think like urination in a public area. If you close all the bathrooms in Chinatown at night and people are homeless, they really don't have a whole lot of choice. Everybody has to use the bathroom. So that's an example of maybe a citation that we would categorize as related to homelessness, but not as a direct result of that homelessness. So when you look at these ones that are result of homelessness, the majority, 74% of them, were park closure or camping. So related directly to simply not having a place to live or sleep at night. And that's what we're talking about in the low-level offenses. Another thing, like I was talking about substance use a little earlier, only about 12% of the citations were related to substance use at all for those clients before they were referred to our program. And only 2% of those were illicit. The majority are alcohol related. And the rest are tobacco, tobacco smoking in where you're not allowed to smoke, essentially. I've got a participant that has been muted. Give me one moment here. Sorry about that. So I just kind of wanted to highlight that information. I gotta get back to my screen here. I'm going to really quickly go over a little bit of how the LEAD pilot works here in Honolulu. That initial screening when they're referred from law enforcement is pretty simple. We're really looking for to address any immediate needs, that they might have, any current legal obligations, setting up a time to follow up, and identifying the goals that they want to work on, that the clients want to work on. Clients that maybe either don't want to be involved with the program, or maybe they have another service. We don't want to duplicate services here. We'll maybe reconnect them to that, get them to a shelter if that's what they want. But we do still offer them assistance. It's more of just like one-time things that can help them move along and get to where they want to go. But for the rest, we work through them, and they get connected to a case manager for a very long time. For long, again, this is a long-term care intervention. Clients aren't time limited in their program. They can stay as long as they like. The only thing that might get them maybe removed is if they're engaging in violent behavior. Again, referring back to that idea of public health versus public safety. We're public health. We have to trust public safety officials to do what they need to do. But most of the time, clients are happy to stay within the program and follow the very, very low barrier rules to stay engaged. And even if they were to become, maybe they go off for a month and not reach out, there's always room for them to come back and work on something else. We try to keep the case loads very low for our case managers, and we guide them by acuity. We assess their acuity on kind of the difference between like high needs clients and those that maybe just need a light touch. And again, those services are driven by what the client wants to work on. You can again refer to our second year evaluation, but you can see kind of the really long-term spread here that I have on the slide of what the clients identified at their initial intake as what they needed: case management services, permanent housing, transportation assistance, and how those things decreased or changed over time. And that's really what it's all about. The clients didn't, we're not going to complete a service that they need and then they're done. They can stick around with us and change what they want to work on. If, for instance, maybe they get housed. Some of the outcomes that we saw that we were most happy with, again, please refer to the 2-year evaluation. We saw an overall decrease in substance use, a little bit, not as much with alcohol, but especially with methamphetamine use. And this is self-report. This is clients identifying how many days that they use. We're not an abstinence-based organization. We're going to work with them and celebrate any positive change. That is what harm reduction is all about. But to see a 23% decrease in their methamphetamine use across the board, averaged among all of the clients, is a pretty sizable or pretty important impact that we'd like to showcase. Another one, meeting housing goals, even though we're not a housing program, or LEAD is not a housing program, I'm sorry. We did see a substantial, decrease in people sleeping on the street, an increase in the time clients had spent in living in an independent apartment, but also things like just a lowering of stress and an increase in hope for the future. And then referring back to those things that are more of a community impact, we saw about a 56% reduction in emergency room use as well. Also, clients had a chance to report to us what they appreciated most. And here's a few of those stories. Even though we don't require them to work with probation officers, we certainly encourage them in that collaboration if they want to. A client here was happy to work with their case manager to get off probation. We've also had a lot of really great collaboration with the community outreach court here in Honolulu, getting clients, allowing them to reduce their citations and their sentences to community service and get those cleared. We had one client who was with us since the beginning, ended up getting reunited with their family and their grandkids. And even though we don't require sobriety, we certainly encourage it for those that are wanting to work and take steps towards that goal. One client identifying that they have been able to maintain sobriety, gotten certified through the entire substance use treatment continuum, which is a very long journey. and had a healthy baby girl. Those are just some of the kind of outcomes that we really like to celebrate. With that, thank you all for listening to the presentation portion. I'm going to stop the share here and give us a chance to answer some of your questions.
What do you need to make LEAD even more impactful and meaningful for community members?
Again, I'm sorry I cut my mic there. One of the questions was, what kind of support do we need to impact more of the community? And actually, I'll open this up first. Greg or Doreen, if you have any.
One area that we found on Maui that was really helpful was the use of stabilization beds. I know when I visited the LEAD program in Seattle, the North District was a high utilizer of stabilization beds. It was very helpful for the police officers to have somewhere in their toolkit to be able to provide a service for somebody to get stabilized. Sorry, I'm sitting in siren roller. So anyway, we found it to be very, very useful for both the shelter and for mental health Kokua. We were able to provide a place for people to go for a period of a few days to maybe even a few weeks, sometimes a couple of months. And the reason for that is they might have psychiatric issues that need to be resolved, and that really helps them. It's better than just going into the emergency room or going into a crisis bed. This way they have time to kind of get stabilized. And at the shelter, they sometimes have co-occurring medical conditions, and that provided them a chance to get their medical conditions under control as well. So that's one of the big features for us in Maui. Doreen, did you have anything else to add to that?
Our outreach worker has done an incredible job of engaging the probation officers, the judges, prosecuting attorneys. So she works really, really close with the court system, which has been extremely helpful. They've dropped a lot of charges that were previous charges for our LEAD clients. And I think having that relationship is very important. Otherwise, if people have multiple charges, and if they're not willing to drop earlier charges, we end up with them back in being arrested and back in jail. So having those relationships, I think, is extremely important.
I'd really like to echo Greg. Thank you, Doreen and Greg. I want to jump in. I'd like to echo Greg on stabilization beds. That would be a wonderful blessing for us to have and be able to give our clients, especially, you saw the numbers, clients with alcohol use disorder, one of the most difficult, they're using it in public. That's why they're getting citations. So if there's a place where we could hold, give them and make sure that they were safe, that would really stop a lot of those kind of problems. Another example, we're really hoping that now that there is a new prosecutor here in Honolulu, some of those changes, maybe a little bit more collaboration with the prosecutor's office here, a little bit more collaboration with HPD, and kind of bringing them in the loop. You got to see some really great examples of how well that's working for Maui's LEAD program. We'd like to see a little bit more of that here in Honolulu as well. They mentioned that they have diversion. Most of ours is actually through social contact in Honolulu, where a client, instead of having an arrest hanging over their head, a police officer or a sheriff will just reach out to us and say that this person needs help. Can you help them? And we'll follow up, bringing them more to the table and having them involved in that case management. When you see folks in Seattle, all of the LEAD pilots, by the way, got to go to Seattle to kind of see hands-on what it looks like after 8, 10, 12 years of working right. You have you have the prosecutor's representatives sitting there. You have law enforcement officers and case managers all sitting there together, collaborating genuinely in the best interest for the clients that are there. So that's a really great example of ways that they can, of things that we have to look forward to.
All right, we have 2 questions on funding. is LEAD going to get more funding, and will there be funding for stabilization beds on Maui specifically?
A couple of questions, if you could, that you folks have been asking about funding, specifically about LEAD getting more funding and more funding in for stabilization beds. I'm not sure about stabilization beds. It's looking, my understanding is that, you know, those things are posed to the legislature. That was making its way through the legislature last session, but because of COVID, a lot of those things kind of got tabled. I certainly hope that they resurface. But as far as funding, I will defer to Greg and Doreen for anything regarding Maui. You know, for our program in Honolulu, we have always looked for private grants to supplement the program in addition to the Department of Health. The LEAD contract specifically ended, but we've transitioned it to offer some other services in the A.D model through their program, through one of our other contracts. So the funding style has kind of changed now that we're out of this pilot phase and looking to expand in Honolulu. But we are doing our best to look for grants and to get things supported, but we're doing just fine for now. I'll definitely defer over to Greg and Doreen.
So for Maui, we do have a current LEAD grant. After COVID, it was reduced, and so we are working on a limited budget, but also we are looking for outside sources to fund the program. And they do pay for our stability beds, not quite at the same rate that they were before, but we're very happy to have them paying for stability beds at all.
And new funding is going to be difficult, as you can all imagine, because COVID has devastated the state budget. So existing programs that are effective will probably be maintained, at least maybe at a reduced level, but new funding is not going to be promising for the next year or so.
Does LEAD have separated programs specifically for LGBTQ plus homeless population, especially the transgender population? And a follow-up, if not, who do we work with?
So a little bit of a question about LGBTQ individuals with LEAD. We do ask for those clients that feel comfortable sharing about sexual orientation, sex at birth, and how they choose to identify here at Hawaii Health and Harm Reduction Center. I think that when you look by the numbers, and forgive me, I don't have it right in front of me, but it is in our report, about 7%, if I'm not mistaken, of the clients that were enrolled in our program identified as transgender. The limitation for us is not whether or not somebody identifies a certain way, whether it's their sexual orientation or whether it's their gender identity. It is that law enforcement is the primary portal, and or at least in Honolulu, there is a site restriction or a footprint restriction for those clients that are eligible. Again, we had to try to keep it in that footprint of District 1, Sector 1, and kind of around that area for the pilot phase. So, I mean, if it's definitely something we talk about. We collaborate with our clinic here at Hawaii Health and Harm Reduction Center. We have a lot of services to the transgender community, to the LGBT community, or the LGBT, forgive me, community, including HIV services. So all of that is part of the mix. We definitely refer them, but LEAD is more focused, on whatever the client really wants for us, but also, trying to mitigate a lot of those criminal justice harms. I hope that answers the question. Greg and Doreen, feel free to jump in if you have anything for Maui specific.
I would just echo what you've stated. We respect and we ask what people prefer, but we don't have specific programs.
Next question.
Do you have data on the ages of clients? I work with youth and would be interested in data related to folks 18 to 24 years old.
Of course. after this session, I will go back. You can log back into the session, or feel free to reach out to me. My contact was on the slide, but it's dshaku@hhhrc.org. I'd be happy to send you, anybody in the session, our reports. It does have all of that information: age, gender identity, all of those things, along with some of the progress data as well. I'd be happy to share that with anybody who's interested.
L.E.A.D tend to save per individual successfully diverted? Are there statistics available?
We don't currently have specifics on the money that it's saved in our evaluations. That's something that we would like to see maybe in a more long term. I wish our evaluator was here. He has a lot of really good, he's done a really good job of kind of explaining why that's so difficult to get and quantify. But it is definitely something that we want to look at. Kaipo actually hinted at it, and I'll definitely open it up to Greg and Doreen for what data they have, because stabilization, they're more involved with stabilization, and so they've got maybe some more information about cost. But for Honolulu, at least, some of the things that we'd like to track: how do you define how much money is saved when somebody doesn't have to cycle through the criminal justice system or constantly get different citations because they're housed now and they're not going to get citations for being in the park after hours. We haven't quite gotten that sorted out, but it's definitely data that we'd like to have for the future.
I can jump in and add to that. There's been some national studies done over the last few years, and so the average cost of homelessness, it's got a broad range across the United States. So it ranges about $35,000 to $150,000 a year per person. And so what does that include? Well, it includes all the public resources that somebody might use, such as emergency rooms, the ambulance services, medical beds, psychiatric beds, police department, all those public services. That's why there's such a broad range. It's about $35,000 to $150,000 a year per person for a homeless person. Whereas to house them or to keep them safe, it's ranging right now about $30,000 to $35,000 a year per person. So the significant cost savings to the community to be able to keep the person housed. As David was saying, I'm not sure we have specific Hawaii data, but we can kind of infer that from the national research that's been done.
Where or how do you see your initiative evolving in the current social and political context?
That's a really good question. Looking at the current socio-political context of L.E.A.D, there's been a lot around the Black Lives Matter. If you actually go to the National Support Bureau, the L.E.A.D National Support Bureau website, there's a lot of looking at ways in which L.E.A.D can transition away from that law enforcement referral portal and more to a community-focused model, and kind of really support that community policing model, or a lot of the other jurisdictions. I don't have them up in front of me, that are kind of experimenting with different ways to empower that public health and take away a lot of the responsibility of public health from public safety, and give it to public health and empower that. One of just on the surface, L.E.A.D National Support Bureau is changing the acronym to Let Everyone Advance with Dignity. That is, and so that kind of housing that, opening it up more away from law enforcement being the only people who can refer, and giving it more back to the community. Kaipo, I keep referring back to his presentation earlier. He talked a little bit about how law enforcement is, and I'm certainly no expert in law enforcement. I'm not a law enforcement officer, but to my understanding and from the conversations I've had with law enforcement officers, it is community driven and community phone call driven. So they are driven by the calls that come in. If those calls are consistently about people who are trespassing and being where, being homeless or having clear signs of poverty or mental illness. That's what they have to respond to. That's what they're required to do. And so when you, in a lot of these different communities, when you bring forward community and giving them the ability to refer directly to social service providers, that's something that a lot of these places are playing with. I'll open it up to Greg and Doreen for any comments you have about this sort of new social climate that we're in.
Well,
Yeah,
go ahead.
Go ahead, Doreen.
So our outreach worker, she goes out with the officers, and the way they approach, the way they look is very different than traditional policing. They approach all three of them together. They're not in the uniform. They're in a different uniform. It's a t-shirt, a certain t-shirt and black pants. They're not coming on as police officers. And our outreach workers allowed to do a lot of things that the police officers wouldn't generally do. They can take people aside, talk to them about drugs. They can talk about different things that police officers generally can't approach or can't turn the other way once they see. So I think working together and having our outreach worker just builds the trust in our clients that they do have different options, and they're not always just immediately going to be arrested for illegal behaviors.
And then adding to that, I think lessons that we learned from the LEAD program in Maui is that there's all these calls for police reform and that kind of thing. I think if this is, I think LEAD is a prime example of what we would like to see happen with police departments. It's been such a close, rewarding relationship with the police department in Maui. They have been our partners in this whole process. We need the law enforcement people. We need them. And you look at it from the police perspective, what resources do they have in this situation? They may have received certain kinds of training on how to deal with someone who's mentally ill or a drug user. They've learned communication skills, but really what other kinds of resources do they have? And they can do arrests, they can intervene, but how long does that last? They usually, if someone might be arrested, it would last for 24 hours. That takes the person out of the situation for a little bit, takes them away from a local business, for example, but they're going to be out in 24 hours. So what does that really do for someone? I have HPD in my family, so I hear it all the time. You get a call, a police officer might be even reluctant to get involved because the person might urinate in their back seat. And what are they supposed to do with the person? They do the best they can under the circumstances. Police have a lot of expectations by the public, but they have very few resources. We really need law enforcement as our partners. And LEAD offers an ability and what we really discovered from, as David was describing earlier, from the Seattle example, was how you can get providers and police together to really combine resources. So you link together to work together, and it provides really a whole new way of looking at how you do community services. And so I think the LEAD program is it's done a little bit differently. I mean, Maui's different than Oahu, for example. And it's been done differently in every city, but you can see just the possibilities there that you have for providers to work closely with the police officers to really help make a difference in someone's lives.
So for the next question, keep them coming, folks. Thank you very much. Is how has the COVID-19 pandemic impacted your program's interaction with clients and your law enforcement partners? And I'll open it up. Greg and Doreen, if you want to respond first, because you folks have a really great collaboration with Maui Police.
Doreen, you may want to add to this, but we have a series of, as most of us providers have, that do outreach. We have our own safety precautions for follow State Department of Health and CDC guidelines for social distancing, masks. Sometimes we use face shields, rubber gloves, sterilizing equipment out there. But we've continued to provide outreach services, even though in other services we've done more telephonic services, but you can't do that with homeless outreach, for example. So we've continued to go out. We've also done testing for our staff just to make sure everyone is okay. But we have continued to be in the community, and the police officers have continued to work with us. But we constantly tell our staff, and we have to constantly tell our staff, because they're a Wonder Woman out there. Our two female people in Maui, they're just amazing. And we have to keep telling them, you're not superheroes, right? You need to be safe and take precautions. But again, we've managed to provide services anyway, in spite of the pandemic. Doreen, did you have anything you want to add to that?
No, I think you've pretty much covered everything. That we're continuing services. We just do more meetings through Zoom. Getting some of the outside resources, getting their, everything we're all going through. It's just a little bit more difficult getting some of the needs taken care of our clients. But overall, the program still continues as it was prior to COVID.
Thank you, Greg and Doreen. For Oahu, or for Honolulu Lead, I think one of the things that we were most excited to get out there is, once we realized that our contact was going to be really limited, we kind of jumped up. We got some phones for our clients, and tried to make sure that we could at least stay in contact with them, even if we couldn't always go out safely to meet with them. There were several phases of lockdowns. It really impacted a lot of things, like the coordinated entry system. None of our folks would have been able to be housed without, by the way, Partners in Care, Oahu Partners in Care, for the coordinated entry system. But as a lot of those systems were kind of adjusting to what needed to happen, simple things like a client's ability to get an ID being completely shut down was a real wrench in a lot of people who were in that housing process, at least within our clients. So getting them a phone so they could be in contact and we can get updates to them, that was something that we jumped up, and actually ended up transitioning into an entirely different support. We ended up getting, here at HCRC, a private grant to do our CCRP program, which was really just trying to get phones out to formerly incarcerated individuals with some pretty low barriers. And we did that as best we could statewide, getting those phones out, thanks to a really generous donation. But for our lead clients, we were able to get phones out as well. And that really helped mitigate some of, I think, the barriers that they might have faced without having contact. Not everybody kept the phone, but the majority really benefited from having that, and being able to check in with their case manager at a distance safely. That's been a very big help. Any other questions? More questions?
No more questions in that.
Okay. I'd like to just pose a question. Actually, no, I think that if there are no other questions, I'll give everybody a chance. If you have a burning question, feel free to put it up in the chat. But other than that, thank you, Greg, so much. Thank you, Doreen, so much for joining us and giving us the snapshot of LEAD in Maui. Thank you to Andy, who's right next to me, moderating the chat for you folks, moderating the questions. Very helpful as my Zoom monitor instead of room monitor for the conference. But with that, I guess we'll say farewell. Thank you again, everyone, for joining us for this first day of our conference. I hope that you all have a wonderful, Happy New Year to you all. And